Welcome, everyone, to the last part of the series on responsible AI, organized by the AAAS, thanks to a sponsorship by Hitachi. My name is Ilana Harris, and I'm the Senior Program Associate in the Science and Responsibility, Human Rights and Law program here at the AAAS. Today, I'll be standing in for Jessica Widam, the director of that program. AI is a tool. As a tool, it can be used for lots of beneficial applications, but its use also has serious implications. When applied to health, AI can improve diagnostic, treatment. It can even improve access to healthcare. But how does AI-based algorithm gets its result? Can it be tested? Can it be trusted? What are the legal and ethical implications of using a black box algorithm for health decisions? So today, joining us to speak about these issues are Dr. Siu-Kwan Tang and Professor Nicholson Price. Dr. Tang is principal research scientist at Hitachi America. He has more than 15 years experience in machine learning and has worked on subjects ranging from predicting risk for hospital readmission to improving radiology workflow. Dr. Tang has a PhD in statistics from Stanford University and has received several patents linked to healthcare informatics. Professor Price from University of Michigan has written multiple articles on AI and health, ranging from examination of medical AI and contextual bias, which I hope we can touch on today, to articles in the popular press. Professor Price received a JD and a PhD from Columbia University. So to ask questions please use the comment section and give your name, and if you are so inclined, the location of your connection. So let's start with you, Professor Price. You described 4 roles AI could play in the medical system. Would you mind summarize what those 4 roles are?
Sure. So I think we can imagine AI doing lots of things, but I envision it kind of fitting into 4 different ways that it can interact with the medical system we have right now. So the first and kind of the sexiest, the big headline topic is pushing boundaries, which is to say there's stuff that human doctors and human practitioners can do now, and ideally there are some forms of AI that'll be able to do things beyond what humans can do now. So say predict whether or not a patient's going to go into cardiac arrest or suffer acute kidney injury before human doctors of any skill level could possibly predict that, so that we can intervene earlier and provide better care. A second big role is democratizing medical expertise. It turns out there are relatively few specialists in the world, and there are even few truly superb specialists. But we'd like everybody to get treated in the best possible way with the most possible skill. And so one possibility is that AI can amplify the capabilities of physicians or other providers of care and let them do things that they otherwise couldn't. So your general practitioner might be able to do things with AI that otherwise only a dermatologist could do. The third big role I think of is allocating resources. So saying, if we only have 1 bed in this hospital, which patient is it most likely to benefit? And thinking about how to allocate resources to that patient as opposed to someone else. This is obviously not without controversy. Then the last role I think of for AI is what I think of as automating drudgery. There's just a lot of stuff in medical practice that doctors really hate because it's boring and because it's not fun. They hate paperwork. They hate filling out records. They hate looking through records for information. And if AI can help us do that by speech recognition, by categorizing information, by filling out patient records, or by finding the most relevant information in patient records, that could be transformative to the medical system as well.
Wow, thank you. So, Dr. Tang, your work touches on some of the item mentioned by Professor Price. Could you explain exactly how you use AI in medical setting in your own work? And also, how do you measure or establish the success of your algorithms?
Okay. Um, some of the work I've been involved in or are aware of does touch those areas. For example, we apply some supervised learning techniques to try and predict clinical deterioration of patients so that the doctor can be alerted to patients who might be facing imminent deterioration and would assess and treat them in the hopes of improving their outcomes ultimately. And some of the work may have to do with drudgery. For example, radiologists have a lot of paperwork to do, and we want to help them create the radiology report by applying some automatic ways to infer some sections of the report based on some other sections that have already been created. And as for how we test to validate, there are various standard ways. For example, we need to set aside a test set and not use the test set for the model building and apply the model that we have learned on the training set to the test set and see whether the performance that we get hold up in the test set. This is a standard practice to avoid overfitting. That's a basic way. But more importantly, we need to get the experts involved and run our ideas, our models in close collaboration with the doctors who gave us the problem in the first place to work with, to see whether things make sense.
I see. So you mentioned the test set, and Professor Price, you have published a paper on contextual bias. So could you please explain what you mean by this? And also, then the question to you, Dr. Tang, would be, how do you address this issue?
Yeah, so the real challenge is, so there's this widely validated and widely used set of techniques to make sure that the AI isn't just overfitting information and is actually finding real relationships. But those are quite frequently used just in the context of one specific setting. So if we're training AI in a hospital, we'll train it in that hospital or a small network of hospitals or something like that. And the question is, well, how well does the algorithm or the product perform when you take it outside of that context and show it entirely different patterns of care, different patient patterns, different patient populations? Like, how brittle is this algorithm to context, and how much can we say, yeah, when we take it and we developed it at Stanford and now we're applying it not just at, say, another fancy school, but rather at, say, a community hospital? Does it still work then? Does it work technically, but also does it tell us the right kinds of things about patients and about the care we should be providing?
Yes. So, Dr. Tang, how do you address that kind of issues?
This is an important problem because what the model is doing is learning patterns from the training set. When we apply it to a different environment, all sorts of things could go wrong. The most benign thing that might go wrong is you get lower accuracy, but it could be serious errors. For example, you might make really wrong recommendations. There are some technical ways to try and get around this. I think just by being aware of possibility that you are applying the model in a different environment, that's the first step. That means you can then, as a data scientist, look out for such problems. The technical way, one technical way to address this is to retrain your model on the target environment. Sometimes that's not always possible because you might not have enough data. That's when certain techniques that have emerged, like transfer learning, where you try and still borrow some information from the source environment, let's say Stanford hospital's data, a lot of cases, and try and borrow some information while adding data from the target environment, which is less. And gradually over time, you adjust your model so that it's learning more of the relationships of the target environment. In general, this is called transfer learning. Another aspect is you need to be aware of what the model is figuring out. What are those relationships? Can you explain the model? And if you can explain the model, it makes it more robust. If you can go over what the clinical meaning of the model is, what those meanings are, then it's more likely that you'll catch errors from contextual bias. And lastly, I think we shouldn't look at the model as a static thing. What we are delivering is actually a system, and it comes with an environment for maintaining, reviewing, and improving it, so that there's a continuous process of collecting better and more relevant data in the target environment.
Yeah, do you mind if I respond directly?
No, please do.
So I love this. I think obviously I totally agree. One of my favorite stories, just in terms of kind of what is the model actually learning. I don't remember the hospitals, but there's this wonderful story. Wonderful and terrifying story of an algorithm that was trained to identify, severe pneumonia from chest X-rays, and it got really good at it. And then they tried it at a different hospital, and it really didn't work well at all. And it turns out that what the algorithm was really finding was what kind of X-rays it was being asked to interpret. And so if it was being asked to interpret X-rays that were taken from kind of a fixed X-ray machine versus a portable X-ray machine, and it turns out when patients have really severe pneumonia, you bring the X-ray to them rather than the way around. And so when they switched to a hospital that didn't have that same practice and that same set of machinery, the algorithm totally messed up and didn't know what it was doing because it learned exactly the wrong thing.
I see. Sorry, Professor Dr. Tang, do you have any follow-up on how do you make sure that the black box is in a way open? I mean, how do you open this black box algorithm, this black box medicine?
Yeah, recently there's a term called explainable AI, XAI. I think it encompasses a lot of things. Starting from the basic, what are the influential features? Meaning, if you keep everything else the same and you change one feature at a time, what is the impact on the model output, model prediction? That's a basic concept. There's a more general concept of feature importance, which tries to look at things like what is the impact of omitting that variable or that feature on the model performance. These are kind of technical measures, and people have devised very useful ways of calculating such measures and visualizing them, which are helpful. It's also important for the model to characterize when it might fail. What are the confidence intervals? Instead of just one number, how confident are you about the number? That's a way of opening the black box. I've attended some seminars and conferences where I've seen more general characterization of what explainability means. And in fact, it does encompass things like, is it scientific what you are discovering? Also, if you implement it in a system, not just a static model, but a living system, what is the accountability measures in case things go wrong? And what is the trustworthiness of such a system? I've also heard the view from a doctor recently that he, depending on the application, you might not care so much that it's a black box. If you are not replacing clinical decisions by an expert, then by all means, you might just use the output. For example, to warn the doctor, oh, this patient is deteriorating, you might want to take a look at it, at the patient.
Yes. So the question of the black box goes to you, Professor Price. You're a law professor. So do you see any prospect for regulation in a way of forcing the healthcare industry to open the black box? Do you see new regulation in AI healthcare?
Yeah, so I haven't seen much action on this yet. The closest thing we've got, so in Europe, there's the General Data Privacy Regulation, or General Data Protection Regulation, sorry, which includes, at least arguably, a right to explanation for certain algorithmic outputs, but that's really thinking more about algorithms that are used to make decisions about people from kind of a government or corporate standpoint, and less so about medicine. In the US, I don't see much there. The closest thing we've got in the US is that the FDA regulations about what counts as a medical device, and this is from a law that Congress passed in 2016, say if it's software that's used to support clinical decisions, and that software provides enough information to the healthcare provider that we expect them and they're enabled to independently assess the information and make their own decision about what's right and what's wrong, so that it's really just supporting their decision, at least theoretically, rather than making the decision for them, then that doesn't count as medical device. It doesn't count as a medical device, and therefore you don't have to go through FDA to get it approved, typically, and therefore it's cheaper to get the software approved. So there's a little bit of a carrot, in as much as the more explainable it is, the less likely you're going to have to spend money on the FDA approval process, although that obviously has pluses and minuses.
Dr. Tang, in your work, you work with risk assessment. So your software provide the scientist or the doctor with a probability of readmission, and so could you explain how the process works in the hospital or in your work? Like, do they have to follow? Do they have to justify if they don't follow?
Okay, I'd be happy to. This was work between Hitachi and Partners Healthcare, where we were trying to predict the risk of readmissions for heart failure patients. The underlying reason is that patients who, if the hospital has a high readmission rate, less than 30-day readmission rate, then Medicare and Medicaid reimbursements will be impacted. This is in the law in the US, that certain metrics are tracked that impacts the hospital's bottom line. So when we create a model, it predicts based on all the information collected by the hospital about this patient, this heart failure patient. What we get is a score and some confidence about that. And how our client, Partners Healthcare, intends to use that is to look at the riskiest patients and suggest that they enroll in their hospital readmissions program, which has been proven to be effective at reducing readmissions. That program, I think, involves closer monitoring of the patients after discharge, so that there's a lower chance that they'll need to come back.
I see.
It's effective, but they cannot enroll everybody because it's costly. So this is a cost-effective way to select the riskiest ones.
I see. Let's switch to another topic that is also of interest for people doing AI and health, and that's the subject of privacy, which we haven't touched yet. Dr. Tang, again, could you basically summarize the privacy setting, what data is available to you, how you handle it?
We work with clients to get data so that we can solve actual problems related to healthcare. And in the US, HIPAA requires that our client de-identify the data before they can pass the data to us. Of course, our responsibility as receiving and when we receive the data, our responsibility is to make sure that we keep it in a secure location and we take the confidentiality of this data very seriously.
Thank you. Professor Price, do you have any comments on privacy issues?
Yeah, so, the HIPAA's a weird law. HIPAA was passed at a time when we thought that health data were really data that were generated in the context of a hospital or a physician's office, and it turns out lots of other data we might also think about as health data. It was passed at a time when we thought if you don't have, a name and an address and an age and some other information about data, then it was really de-identified, and it would be hard to re-identify those data. And both of those things I think we've realized really aren't true anymore. Data about your shopping habits and your internet browsing habits and whatever else are all to some extent health data that HIPAA just doesn't cover. And data that HIPAA says, oh, these are de-identified because we've removed certain pieces of information from them, are pretty easy to re-identify when we've got oceans of big data hanging around, and in particular when we've got smart algorithms that can trawl through those oceans and find out lots of information. So, no, I'm not saying exactly how much I'm worried about all the privacy risks, but one thing I'm quite certain about is that HIPAA really isn't designed for the data privacy concerns that we have today.
I would like to add that there are some things that are not covered by the law, probably. We also abide by ethical principles. For example, we do not try and re-identify the data because that's irrelevant.
That's good.
Our problem, and sometimes that's covered in the contract between our client and us.
Yeah, I'm casting no aspersions, I promise. Just in terms of kind of what does the law do, what does the law require? The answer is honestly, not that much, not that helpfully, but so.
Oh, perfect. So I guess one of the questions we could ask is for someone just coming into contact with the not so distant future, what is one thing that everyone should know about AI in the not so distant future? And also, how do you see personally the AI driven future in the context of healthcare? Do you have specific worries, or do you have specific aspirations?
So for me, I think the thing that you should know is that AI is going to be everywhere. Whether you can see it or not, it's going to be embedded in the electronic health systems that are present throughout medical care. It's going to be behind the scenes. It's going to be doing things like deciding which providers get which shifts, who gets what resources, how insurance is billed, how reimbursement is contested, whether or not an MRI gets sent to a radiologist or not, or which radiologist it gets sent to. It's going to be everywhere. Now, I have two visions of AI, and I don't know which one's going to happen. I imagine both will to some extent. One vision is a really optimistic one, where AI really frees physicians from a lot of the things that, frankly, machines are going to be really good at, like recognizing patterns and making diagnoses and figuring out what pictures look like what, and automating tasks that physicians don't want to do. And that'll free up a lot of physician time for caring for patients as humans, and interacting with them and saying, what's really important to you as a human, and how is it that we can shape the care that you receive to the person that you are, and not just a set of biological phenomena. The scary, the less optimistic vision is that it will basically get layered on top of the system right now. It'll provide second opinions for high reimbursement rates and not change much, and just kind of create more work. But I'm hopeful that this can bring more humanity back into medical practice.
What about you, Dr. Tang?
Yeah, for me, I'm concerned about the alignment or misalignment of incentives amongst the different players. For example, payers, and the patients and the hospitals. When insurance companies use AI, is it really for the patient's benefit? I think in order for that to happen, you have to make sure the incentives are aligned and proper legal framework and policy discussions take place before we go too far in making decisions using AI. That's one of my concerns. I think it has a bright future, but people need to be aware of changes that involve AI.
But as a practitioner of AI, Dr. Tang, what capacity do you predict from your system? How far?
Yeah.
How far do you think you can go?
Yeah, already there are a lot of things where, for well-defined problems, algorithms can either match or exceed the expert performance. For people who are curious, you can read up an article on IEEE. This was from about 2 years back, called AI versus Doctors. And there they have an interesting infographic, kind of a tally of different problem areas where AI has won, or the doctors are still the best at the task, and some in between as well. For example, detecting pneumonia, AI is very good at, and detecting skin cancer from images is kind of a toss-up. But there are also areas where AI is vulnerable to hacking. For a malicious actor that knows how the AI is classifying images, some researchers have found they can change just a few pixels in the image to fool the algorithm. In an extreme example, of course. I think AI is going to keep improving. The most prominent examples are from computer vision. It's really about how we want to apply those capabilities and how we use that in conjunction with experts, with doctors, to improve outcomes. I think that's the main discussion.
So if I can just add on a little bit to that, I think that's exactly right, that a huge part of the decision is how, or a huge part of what happens is going to be, how does AI interact with doctors? But I also think that if we focus just on that, we miss a really big picture, really big piece of the picture, which is to say, there are millions, if not billions, of people who are going to interact with AI instead of doctors, not in addition to doctors. And it's easy kind of sitting where we are to say, well, of course, the question is when I go see my whatever, how will she interact with the AI that's available, without recognizing that there are billions of people around the world who won't see their specialist for whatever. And if they get care, it might just come from AI, or it might come from AI helping out someone with minimal training or a little bit of training or some training, but not the same sort of kind of interaction that we're envisaging. And so I think it's useful to keep in mind that, yes, we're developing AI in a particular context, in a context of pretty abundant medical care, but a ton of examples and ways that this really works are going to be in very, very different situations.
That's an optimistic view of the future. What I'd like to conclude by thanking both of you again for your time. Many thanks again to Hitachi for their sponsorship, and a special shout out to Colin Yannick from Hitachi DC office. You can watch the entire series on responsible AI on our website, and the website should appear either in the comment or on the screen. Thank you very much again.